Someone's going to trip on this, eh? I know.
But I told them I'm okay with going on the side and just putting the mic down.
Yeah.
But they said,
No. Just
be careful.
be careful sneaking up on us.
Yeah.
Hi, folks. Hi, folks. We're going to get started. If you're in line for lunch, just continue along. Just remember, we want to get the talk going because we have a full slate of afternoon stuff to get through, and we want to at least be somewhat on time. So get your food, but you'll get to listen while you're in line there. Welcome, everyone, to our lunchtime symposium, Name That Rash, a problem that we see a lot of in the Emerge and often really struggle with, and so hopefully this is going to answer some questions for us. I'd like to thank our speakers and moderator for being here today. I'd like to thank the sponsors of the symposium, and I'll put my 100th plug in for evaluation forms. Fill them out at the end. I'll probably remind you at the end too. Thanks very much, and I'll call our moderator on up.
Hi everyone, welcome to the Lunch Symposium today. Our work today is in the spirit of moving toward reconciliation and anti-racism through culturally safe care. We'll begin with a land acknowledgement. Canada's treaties and ongoing relationships with Indigenous peoples is a current and ongoing process. As we gather here today, we acknowledge that we are on Treaty 6 territory and the homeland of the Métis. We pay our respects to the First Nations and Métis ancestors of this place and reaffirm our relationship with one another. This meeting place is home to many Indigenous people from across Turtle Island, and I am grateful to have the opportunity to be here with you today. For those of you who don't know me, my name is Sachin Trivedi. I work here in Saskatoon in emergency medicine and transport. I'm also the volunteer chair for CAEP24, so you've probably seen me hanging around the registration desk the last couple of days. I'm also the chair of CAEP's Quality Improvement and Patient Safety Committee. Our symposium topic today was independently conceived by the Scientific Planning Committee. So that's Drs. Jennifer Bryan, Eric Clark, Brittany Ellis, Catherine Patoka, and James Stempion, none of whom have had any conflicts of interest to declare. My disclosures are as follows. And then these are the disclosures for our speakers today as well. This presentation was made possible by educational grants from Boehringer Ingelheim Canada, who I'd like to thank for their generosity. All efforts were made to mitigate any potential biases. And our speakers this afternoon are Dr. Rachel Asiniwasis and Dr. Tetyana Maniuk. So Dr. Asiniwasis is a dermatologist and an early career clinician researcher based in her hometown of Regina, Saskatchewan. She's the founder of the Origins Dermatology Center, which uses a combined multidisciplinary model to service the general population, as well as providing outreach clinics for underserviced, remote, and rural Indigenous communities, both in person and virtually. Rachel is of Plains, Cree, Saulteaux, and English background. She carries a master's in health sciences in clinical and translational research and has special interest in common inflammatory dermatoses, virtual care, underserviced areas, the holistic impact of skin diseases, medical education, and translational interpretation and implementation of research with the ultimate goal of tangible health outcomes. She has active educational and research projects in the areas of inflammatory skin disease, virtual care, and Indigenous and rural health in Western Canada. Dr. Maniuk is a recent graduate of the Royal College residency program at the University of Ottawa and is now working as an emergency physician at Queensway Carleton Hospital in Ottawa. She has a master's degree in health informatics from the University of Waterloo and is working with the Canadian Institute for Health Information on their Pan-Canadian Health Data Content Framework, building data standards for primary care. So thank you to Rachel and Tetyana for presenting today. So we're looking forward to an interactive session today. We'll try to address as many questions as we can to the end of the presentation. And we also have some audience polling done through Mentimeter. So you can see here the instructions slide, and you can access it on menti.com with that code, or you can scan the QR code there as well. You'll be prompted to enter the code on the screen, and then answer each question as it comes up. And please remember to click submit so your votes are counted. A little background on today's development. So when someone presents with a rash to the ED, we know it can be hard to diagnose. We know that these patients are always the first ones, or not the first ones to be signed up for. And especially with their rare skin diseases, things can be a bit challenging. So today we're going to give you some examples of differential diagnoses, and you'll come away with a better understanding of some of the more dangerous presentations. These are our learning objectives. I'll give you a second to review them. And we'll go from here. So Rachel?
Thank you. Thank you, Dr. Trivedi. Can you guys hear me okay? So I'm Rachel, greetings from Regina. I just noticed in my bio I put early career, but in 2 weeks I'll be 10 years full-time into practice post-residency, so I've got to change that. Thanks for having me. So I'm also really happy to be also in a conference outside of dermatology, and the nice thing about the skin, and one of the reasons I really got interested in dermatology was it really is a sign of internal and external health, and the skin overlaps with so many different specialties. So when it comes down to the emerge department, why should we care about rashes? Well, again, the skin is the biggest organ. Lots of different things can happen on the skin: infections, inflammation, lumps and bumps, and so forth. And you know, up to 8% of ED consults actually might be related to the skin. And there are certain conditions, you know, a lot of people seem to have the idea that we're busy popping pimples in clinic. But you know, I maybe see a couple of pimples every week because I do mostly medical dermatology in my practice in an underserviced area, and I do a lot of things like immune suppressants, rashes, wounds, you know, quite a variety of practice. And I'm really happy to talk to you about some of these conditions today that require urgent intervention. You can see listed here things like severe cutaneous drug eruptions, immunobolus disorders, angioedema and urticaria, erythroderma, and necrotizing fasciitis, to name some. Others would be acute cutaneous necrosis, vasculitis, autoimmune disease. Again, they're hypersensitivity reactions. These are all things that might present urgently in the emerge department. So why do these dermatology disorders make us nervous? So I remember being an undergrad, and again, I discovered dermatology later into medicine, but I quickly realized that, you know, we didn't get a whole lot of classes or courses in dermatology compared to other organ systems where there tends to be more horizontal and vertical overlap with things like hypertension, heart disease. So I think that that's one reason is we need to look at what the medical curriculum is showing and why perhaps we might not feel as comfortable with certain dermatologic conditions. Also, you know, when disorders are rare, it makes sense that there are no concrete guidelines. There's not things like, I do a lot of atopic dermatitis and psoriasis, for example. These are common conditions. Of course, guidelines are available. But with these rare conditions, again, it's challenging to find, you know, things like randomized controls trials to provide concrete guidelines. Sample sizes would be small. Additionally to that, I remember when I was learning dermatology in our textbooks, and the one thing about the skin is a photo is only a snapshot in time. So if you have vasculitis, for example, you know, you're not going to start out with this obvious palpable purpura and nodules and ulcers right away. There's a progression, right? It might start looking a little bit erythematous, non-specific, and then it develops. Same with something like psoriasis. You might get macular erythema, and then it thickens with time and scale. It's not 0 to 100. So it's also snapshots in time, and that also goes for urgent conditions. Again, you know, the goal of this talk is we can't cover everything in an hour, but we just wanted to make some points about early recognition on certain conditions that require urgent care. So going to morphology, so the first thing in dermatology is the language of dermatology, which is morphology. So when you're calling us on the phone for a consult or we're talking about a patient, I mean, nowadays there's a lot of virtual care available. But really, when you call us on the phone, I'd like to hear, you know, like a morphological description, because that's fundamentally what we use to communicate and form our differential diagnosis is based on the morphology. So to give you an example, maculopapular rashes is truly macules and papules, and the most common causes of a maculopapular rash are virus and drug eruptions. And graft versus host, you can also see it. Kawasaki's disease, there are other things, but again, the vast majority of horses being horses and not zebras, we tend to see maculopapular rashes, also known as morbilliform rashes in viruses and drugs. So that is something that I use from a morphological standpoint to make a differential diagnosis. And as you see here, I don't want to go through all these. It'll probably bring you back to like medical school and residency, but you know, again, these are the words that I use every single day, and So examples, again, macules being, flat, non-palpable, there's no fluid, papules are more solid. It says half a centimeter, about 1 centimeter, I find in a lot of our textbook as well is often differentiating. To give you an example, a macule is less than 1 centimeter, and a patch is greater than 1 centimeter, but they're both flat and non-elevated. And then there are fluid-filled lesions, such as vesicles, which are clear, so they're truly vesicles, and then pustules, which are truly pus. So we're going to talk about some of these and how we can make a differential diagnosis in some of these conditions. Oops, I think it accidentally went too far. Here's another example. So what we're focusing on today is bullous and pustular eruptions that might present to the emergency department. Okay, so bullous, again, so vesicles are small. Okay, they're generally less than 1 centimeter, fluid-filled. Okay, and again, we use those to make descriptions. For example, grouped vesicles on an erythematous base is often HSV until otherwise proven. And then bullous conditions are greater than 1 centimeter and are truly clear and fluid-filled. And the other thing is you can find these in many different areas. And again, this is very limited representation of dermatology. But other things that can help us clue into the differential is the lesion solitary? So if someone comes into my office, the first thing I'm thinking is this a lump or a bump, or is it a rash? And I go into different modes here. So if it's like, a nevus on one side of the body, right? Or is it a rash? Has it been there? Does it come and go? That kind of thing. So whether it's localized, generalized, solitary, multiple, the distribution, symmetrical versus asymmetrical, all of these things on top of morphology and the patient history and exam, we use to kind of narrow down a differential diagnosis and what investigations and management should be completed. So in the emerge department, what are red flags? Acute onset, right? So if someone has a chronic condition like lichen planus, that might not per se be an emergency, but we might have someone, let's say, with psoriasis who has pustular flares, and those can be associated with systemic symptoms. And of course, drug eruptions, things like DRESS, SJS-TEN, so acute onset, abnormal vital signs, things like DRESS syndrome. You can get, drug hypersensitivity syndrome. We typically think of that as like fever, lymphadenopathy, eosinophilia, liver enzymes, but it can affect many other organs. Other red flags is mucous membrane involvement. These are things like SGS-TEN and pemphigus, which we are going to review. And then bullous eruptions. So these tend to be more acute. And again, we're going to talk about why this might be problematic for some people. And erythroderma is over 80 to 90% of the body surface area covered by redness. Again, that can be a risk for things like high output cardiac failure and thermoregulatory disturbances. So the Nikolsky sign, I'm sure some of you remember hearing about this or have seen it. It's not something that I would do to a patient. I think it would be quite painful. But it is a twisting pressure on the normal skin can cause it to detach. And this is found in quite severe blistering conditions. So if you see this is something that we need a dermatologist consult. We are really advocating hard in Saskatchewan to get a hospital-based dermatologist, just so you know, we're all in private practice right now, but I think that's something that is needed here. And these are things like pemphigus, TEN, and staph scalded skin syndrome. So if you see that sign, it is considered urgent. And then we have Dr. Tetyana here, who's going to take the next section. I'm not done yet.
Can you guys hear me if I talk like this? Okay. So we're going to do an overview of drug eruption rashes and how to approach a differential for a patient with a rash presenting to the ED. As you may remember, drug eruption rashes are rashes that develop following a systemic drug administration. Patients who have a concurrent viral infection, who are immunosuppressed, and who are on multiple medications are more likely to develop a drug eruption rash. Typically, these rashes are limited to the skin, but sometimes they may involve the hair, the nails, and the oral mucosa, and that pertains to a more severe rash. Some drug eruption rashes may represent or may mimic a viral exanthem, but drug rashes are typically more polymorphous. They appear suddenly, they appear centrally and move out, and they typically start peaking 1 to 2 days after the culprit drug is stopped, and then resolving 1 to 2 weeks later. So the rest of my section is going to show some high yield diagrams and flowcharts, so I'll warn you when you might want to consider grabbing your phone out to take a picture, because we're going to talk about an approach to the differential. So this is your first warning. This is an approach number 1 to a flowchart for dangerous rashes or dangerous drug eruption rashes. We've already reviewed kind of a general differential for rashes, but this one only focuses on drug eruption rashes. The first differentiating feature is a fever. Fever and mucosal involvement are really the defining features for a serious cutaneous adverse reaction. Is this going to work? Or a scar, or a non-serious cutaneous adverse reaction, or an NSCAR. Afterwards, going down the flowchart, you'll see that morphology is the next biggest feature. If we can't describe what we're looking at, we absolutely cannot build a differential. That's why it is important to speak the language of dermatology. So if you can consider a patient who is presenting with a fever, with mucosal involvement, bullous, with a positive Nikolsky sign, you have to consider SJS or 10 or pemphigus vulgaris. On the other hand, if the patient has no fever, no mucosal involvement, has a morbilliform rash with no systemic end organ dysfunction, you're likely dealing with a morbilliform drug eruption. So on this flowchart, you'll see that the main 2 features are systemic symptoms and the physical exam of the skin. This is really important. I know we've already talked about it, but I will talk about it again. Suspect a dangerous rash when there is a fever, when there is malaise or systemic features, and a patient is toxic appearing. And on the physical exam side of things, suspect a dangerous rash when there is confluence, mucosal involvement, peeling, or blistering, as well as a positive Nikolsky sign. Taking these 2 features together gives your second approach to a differential for a dangerous rash. I like this one as well because we already do this intuitively with a lot of the rashes that we see in the ED. So if you can imagine an unstable patient with an urticarial rash, we automatically think about anaphylaxis, or at least consider it. So we can expand that differential a little bit further to include the other morphologies, such as a morbilliform rash in an unstable patient, thinking about DRESS, a acne eruption in an unstable patient, thinking about HF, and a blistering rash in an unstable patient, thinking about SJS and 10 or pemphigus vulgaris. So even with diagrams and flowcharts, it's still sometimes quite hard to differentiate what the rash actually is. Thus, a brief mention about the physical exam and HPI. I'm going to talk about HPI in the next slide specifically, but I will suggest doing broad blood work for a patient that you suspect has a drug eruption rash to look for systemic and organ dysfunction. And on the physical exam, 3 key features. Number 1, make sure to do a head-to-toe examination to see exactly the areas that are involved. Number 2, see if it's peeling. We already mentioned Nikolsky, so I won't go any further. And 3, see if it is blanchable. Now, it is sometimes hard to see if a lesion is blanchable, so what I've done in the past is I've taken something see-through, like glass or a syringe, and I've applied it to the skin, and then through the see-through material, I've looked at the lesion to see if it's blanchable or not. So I mentioned I was going to go back to the HPI. So the Naranjo Adverse Drug Reaction Probability Scale is kind of a systematic way to go through a history for a suspected drug eruption rash to know that you're hitting the right kind of historical features. And when you ask these questions, the higher the score, the more likely it is going to be that the rash you're dealing with is a drug eruption rash. So specifically, looking at the timing of the drug eruption rash compared to the medication that might be a culprit, if that medication is known to cause these reactions, and if there is a possibility an alternative explanation could be used to explain what the rash is, are features of this history. And speaking of timing of a drug eruption rash, hopefully you're going to be able to see some of this. But this is a drug chart that was created by Dr. Boss from U Ottawa, a dermatologist in U Ottawa. And it takes the timeline of the common drug eruption rashes, and you can work backwards from it to see when a medication might have been introduced and what syndrome you might be dealing with. So for instance, day 0, right here, is when the rash first started. So working backwards, if you think that there is a culprit drug that was introduced the day before, you might want to consider a fixed drug eruption because those typically appear within 1 to 2 days of starting the drug. If you're considering DRESS, the culprit drugs would be between 14 to 42 days onset, and then 14 to 42 days the rash will appear once the medication has been administered. So I'll give a second if you guys want to take a picture. These are examples of drug eruption rashes, and as mentioned, we're going to be focusing on the pustular and the blistering rashes. So HEP and 10 we're going to be talking about later on. But I do want to give a brief honorable mention to DRESS and erythroderma. So DRESS that we already mentioned, it stands for drug reaction with eosinophilia and systemic symptoms. It's typically an unstable patient, specifically a fever, followed by a morbilliform rash or maculopapular rash. Other features of physical exam can include facial edema and lymph node enlargement. Blood work will include neutrophilia and eosinophilia. And while any organ can be involved with DRESS, the most common one is hepatitis, and this does appear into 70 to 90% of cases. Erythroderma is a condition where there's erythematous plaques or edema that encompass more than 90% of the skin. It can be a side effect of medications, but it can also represent an underlying systemic illness like atopic dermatitis or psoriasis. So we showed and reviewed a couple of ways to build a differential of dermatological rashes based on the morphology, the timing, and systemic symptoms. So we're going to go into them in just a bit more detail, starting with bullous eruptions.
Oh, yes, thank you. Okay. Great, so thank you. So the other, I'll grab this from you. That drug timeline I find is really good to get the students and residents doing. It can be kind of time consuming, so it's good to put them on there and it's good learning for them. So if you have that opportunity, let them go for it. So now we're going to talk about an example of a bullous eruption. So these are actually hypothetical cases that are representative of what might be seen for these. And the photos are from our teaching databases and DermNet. So we have a 64-year-old male with hypertension and dyslipidemia, and he presents with 8 months, so that's a clue, okay? 8-month history of progressive erosions of the mouth and flaccid bulli that easily ruptured. He was started on captopril for hypertension 9 months prior. He's been treated for secondary impetiginization with oral antibiotics, and otherwise vitals are stable, and it's been kind of progressively worsening over many months. The primary morphology here are bullous lesions and mucositis, and there is a 30% body surface area. So given this information, again, there are some clues in the history. What would be your favorite diagnosis? So bullous eruption, mucositis, 9 months. Haha. Good. Great. Thank you. And sorry to show these pictures to you at lunchtime. I know the dermatologist can stomach it, but all right. So this, bullous pemphigoid is kind of coming out. And you guys are right in some ways because it is an autoimmune bullous disorder. So it started 9 months ago, just to go back to that slide. They're stable. But this is actually pemphigus. So bullous pemphigoid rarely has mucositis and has more tense blisters. They both, however, require immunosuppressive therapy. They both are chronic. And in fact, there might even be drug-induced pemphigus or bullous pemphigoid in which captopril has been described. So you guys are really close. Like we talk about bullous pemphigoid and pemphigus quite often together. But the answer is actually pemphigus. And we're going to contrast this to SJS and TEN. This would not be psoriasis or AGEP because there's a lack of pustules as the primary morphology. So pemphigus vulgaris, there are some variants, but it is a rare autoimmune disease. It's B-cell mediated. So again, we work with the immune system when treating it. It's characterized by mucositis, bullous lesions on the body, often starting in the mouth. They do have a positive Nikolsky sign, and the bullae are flaccid, whereas in bullous pemphigoid, where the antibodies attack are a little bit lower at the dermal-epidermal junction, so it's more of a tense bullae as opposed to a flaccid bullae. So that's another key. Can be triggered by certain medications, like we talked about captopril. Even there's been some foods like onion and garlic and leek that might be involved in the environmental factors. It's been reported. And you might see some ethnic predilections in this condition. The onset is typically adulthood, and the mortality rate is not as high as TEN if untreated, but again, something that does need urgent dermatology referral. And at this point, we do perform biopsies with direct immunofluorescent, which will clinch the diagnosis. Again, we do work with immune suppressants for these patients and treat any underlying secondary infection. They're often secondarily infected. We use things like azathioprine, methotrexate, and even rituximab. There's no on-label treatment for this. And to contrast this, so some of you chose SJS-TEN, so let's contrast this a little bit. I probably shouldn't have just given you the answer, but whatever, it's lunchtime. So you have a 33-year-old who started on phenytoin following a brain biopsy, and 2 to 3 weeks later, he presents with a fever, rash, and mucositis. So again, this is not 9 months, it's 3 weeks. The rash is very painful and becoming a little dusky. So what would be your thoughts on what to do with this patient? Yeah. Exactly. So monitoring them. Okay, it's acute onset. Remember, there are some red flags. They're unwell. It's a bullous eruption. There's mucositis. Getting blood work is important. Another of the reasons for that is dermatologists. If we have a case of, say, TEN, we often do use things like off-label cyclosporin. And at that point, we would like to have blood work to check their renal function and so forth. Perfect. So I wouldn't recommend necessarily to send this patient home, but again, I realize this is a limited case. So the other thing I wanted to emphasize, whereas things like pemphigus evolve slowly, SJS-TEN tends to happen faster. So you see within 24 hours, you see that there is desquamation, necrotic skin, Nikolsky sign, flaccid bullae, and violaceous changes on the skin. So there's denudation of the epidermis. The skin biopsy returned as full thickness epidermal necrosis, and that's pathognomonic for SJS-TEN, whereas with erythema multiforme, you're going to see partial thickness. And the patient died of multi-organ failure with bacterial sepsis. So this is just full thickness necrosis of the epidermis. And again, that is how we can tell from things like pemphigus. So at this point, assuming they have a body surface area well over 30%, with full thickness epidermal necrosis, 3 weeks, and started phenytoin as a new medication, what would be your favorite diagnosis? Yeah. So toxic epidermal necrolysis is correct, and I'll tell you why that is. You guys are good to think SJS because it's the same biopsy. It has very similar, presentations, but the difference is. I'll go over that in a minute. So SJS-TN, it is a spectrum, and I'm going to, again, touch on that. So this is most commonly reported as a drug reaction. So in SJS, rarely we might see some SJS-like reactions with infections like mycoplasma. There's something called MERM that might mimic SJS-TEN, and they have to be treated often for mycoplasma pneumonia. But again, the majority of these we see often as drugs. And so just like Dr. Tetyana said, 1 to 3 weeks after starting the drug, Mortality rates can be high depending on the number of risk factors. And in residency, one of the things that really helped me to recall this from my Royal College was the common offenders. This also includes, for DRESS syndrome too, you can kind of use it, the A's. So antibiotics like sulfa drugs, anti-inflammatories, allopurinol, antiretrovirals, and anticonvulsants. So again, that's a good mnemonic that I use to remember. And I've seen a lot of these cases. I would say high culprits are the ones I've seen, allopurinol, sulfa drugs, and anticonvulsants seem to be recurrent themes. But again, these have all been reported. So what's the difference between STS and TEN? So it's the body surface area. So if it's over 30%, you'll see of a TEN. SJS is less than 10%, and then there's kind of an overlap condition. And you can see these patients can feel unwell in general. They may have involvement of the ocular, urogenital areas. Yeah, I even had one patient that had her gastrointestinal tract, her esophagus burnt from the TEN. That's what the GI said. So anyways. Yeah, so genitourinary as well. And then you can get, again, dusky erythema, which means impending necrosis, painful skin, mucositis and skin sloughing, any typical targetoid lesions, which you can also see in SJS. There is a severity of illness score called SCORTIN, which I'm going to show you briefly. And here are some examples of patients affected in all different skin tones. So again, you can appreciate that there's this hemorrhagic bullae, which is terming dusky and painful. And then you can see in patients with deeper skin tones that you might have more violaceous gray or hyperpigmented hues, which are signs of erythema. And Dr. Bose, who actually did that drug Rash, is actually working on a lot of projects in skin of color as well. And I'm also happy to know him quite well. So when it comes down to management, it's the conservative management is cornerstone. So if you look at this, like think about it, if the patient's skin is dying, the epidermis is dying, it's sloughing off, they've lost their epidermis. So they're losing their barrier to the outside world. So you might have thermoregulatory disturbance, volume depletion, that should be addressed. Sepsis, generally it's not advised to throw them on broad spectrum antibiotics, but treat infection if it is there. And work up for that with pan cultures. Again, conservative care, as you see here, recommend transfer to ICU or burn unit. And the key here is to stop all non-essential drugs and drugs of, that is like a very major point, and the causative medication. With regards to systemic steroids, what we're seeing is in later stages of the disease, it might increase the risk of poor outcomes or infections. So we generally don't recommend steroids, especially later on in the course. Earlier in the course, it's more of a clinical decision. And again, that's why I think it's worth to consult with dermatology on this. Plastic surgery consult for debridement to remove the dead antigen. Ophthalmology, urology, and often we use cyclosporin. This is all off-label, but often we use cyclosporin these days and see how they do. And often if that fails, we will give them a dose of etanercept, which also has been reported. And then there are others, but that's kind of what most of the dermatologists are doing if they require it. So you guys did really good. The differential between SGS-TN and pemphigus, again, SGS-TN is often drug-induced. It's acute onset. And then histology and a dermatologist can help you tell that difference. Pemphigus, on the other hand, tends to be more chronic and progressive. You can have acute flares, but for the most part, that's the cases I've seen. You can see a positive direct immunofluorescence, and it truly is an autoimmune disease. And there may or may not be any drugs associated. The cases that I've seen often don't. So now moving on to pustule eruption. Just wondering how much time how am I doing for time? Sorry? Okay. So pustular eruptions. So let's say we have another pustular case here. So this is a 43-year-old male who had a pigmented lesion removed and was given a cephalosporin. And 2 days later, so think about that drug timeline, he presents with neutrophilia, high fevers, extensive erythema, and let's see, you culture multiple of these pustules. And they're negative. He doesn't respond to full spectrum antibiotics. So the primary morphology here is pustules. And then when pustules dry up, they desquamate. So crusting can be a sign of a vesicle or a pustule that was there because it's a secondary change. So when the vesicles or pustules burst open, they dry up and can leave crusting. So what would be your favored diagnosis? Yeah, excellent. This is great. I would definitely not do as well as you guys are doing if I attended something outside of skin for your conference. So great, AGEP, yeah, so it's acute generalized exanthematous pustulosis, and we'll talk about why this isn't GPP. I wouldn't put TEN just because the patient is not overly toxic. It's not a bullous eruption, and there's no mucositis. So acute generalized exanthematous pustulosis, or AGEP, you know, in dermatology, neutrophils and pustules, like pustules are actually quite rare if they're sterile in dermatology. Like when we see pustules, the first, as someone who sees a lot of things like infected eczema, you know, and impetigo, boils, fungal infections, you know, when we see pustules, the first thing I think is like bacterial infections, fungal infections, other infections. But if it's sterile pustules, it puts you in a small box. Relatively small box. Again, this is a drug eruption. There's no history of psoriasis. The eruption usually begins quickly. You know, it often begins on the face or intertriginous zones. And we can tell it apart from pustular psoriasis through clinical and drug history, no previous history of psoriasis, and skin biopsy. So this is considered, as you saw in that flowchart, a scar, severe cutaneous drug eruption. Oops. Again, so this is often caused by antibiotics, and this one tends to resolve quicker and be less scary when you withdraw the drugs. Usually it's conservative therapy, but often things like topical oral steroids can be used to speed up the process off-label. And the other thing I'm just going to throw out there is often when I see inflammatory rashes, there is a possibility they could be secondarily infected if there's open impaired skin or if the patient's immunocompromised. So if you see one area that's like worsening, you know, cellulitic, then that's when, of course, you might want to consider a skin infection. So now, let's say you have a male in his 50s with a 30-year history, so it's not short, of chronic generalized pustular rashes. He comes to the emergency department. He's asking to see a dermatologist. He's fed up. And when he flares, he's like, well, I get tired. I have fevers. I have joint pains. And during a flare, you know, he's seeing neutrophilia and elevated CRP. No new medications. The patient has history of some comorbidities, so diabetes, obesity, and in this specific condition, there are comorbidities that have been reported. And depression, and he's previously failed multiple courses of antibiotics with negative cultures. He's stable hemodynamically, so you do cultures, skin biopsies, urgent consults. He's seen numerous diagnoses. He wants to see a dermatologist. There's a quality of life impact. As you can see, there are various pustular morphologies on this slide. So pustular morphology, no drug, going on for 30 years. What would be your suspected diagnosis? Good. This is awesome. Okay, generalized pustular psoriasis. Amazing. Toxic epitope. Someone is doing that to troll me. I'm just joking. Okay. Oops. So generalized pustular psoriasis, although it is a rare disease, it is in some ways a variant of psoriasis. However, with the specific entity, generalized pustular psoriasis, you know, it often is characterized by a different cytokine axis. There may be a family history. And this is a kind of, when we think psoriasis, we think chronic plaque psoriasis, which is like a chronic disease, right? But this is a condition where you truly can get acute flares that are characterized by pustulation, neutrophilia, and systemic inflammation and systemic symptoms, and they're characterized again by studded pustules on an erythematous base that are sterile. And to be totally honest with you, if someone had bacteria all over their body like that, they would be very sick. You know, if they are infected to that extent. It can be, they probably won't be walking into the emerge. Can be relapsing or persisting and can occur with or without systemic findings, as you see here on the bottom right. And you can see again that you can definitely get systemic involvement. And the clinical course can be variable, and what we know, there can be certain flare triggers, like for example, steroid withdrawal is one of them, stress, infections, hypocalcemia, pregnancy. But there are some definite unmet needs with GPP. One of them is being able to recognize it and diagnose it and get the patient to a dermatologist for proper care. Others are in the literature and in clinical practice. We see high rates of failure of the traditional off-label systemic agents, including for maintenance and for acute flares. And you can see it's all over the board what people are using here. But there's a high clinical burn and quality of life impact that we see. And currently the treatment options are off-label and limited. So to differentiate between these two, again, AGEP is, there's often a drug, there's no history of psoriasis, it's self-limited with suspected drug removal, often starts in the flexures, and histology, urgent histology can also help differentiate. Whereas generalized pustular psoriasis has a chronic relapsing course. There may be indeed a long-standing or family history of this. Often there can be overlap with plaque psoriasis as well. And then systemic symptoms and histology. There was one slide that I might have missed. I thought I saw it in the slides. Oh yes, here we go. I hope I didn't skip. Okay, so for management of generalized pustular psoriasis, again, there's only one on-label medication. It's a biologic infusion called spesolimab, which targets the main cytokine axis, which is interleukin-36 receptor antibody. And it's been studied in phase 1 and 2 studies in terms of an IV infusion, and it may be repeated if the patient is still not fully responding in a week and as required afterwards. They're also looking at this as a subcutaneous option in phase 2 studies for patients with ongoing disease. It's worth a read if you're interested, but again, it is an on-label therapy in which, if you look at the data, the efficacy and safety appears to be honest, we need something like this in this disease. Okay. And to wrap up, I have some quick snappers. So I just wanted you guys to vote if you can. So let's say you have a 4-year-old male who has a history of eczema, presents with a 48-hour vesicular eruption, so it's a true vesicles. And remember, vesicles turn into pustules and crusts. Punched out erosions, so that means there were vesicles there. When there's an erosions and crust, it's a secondary change. And they have fever and malaise, and the patient has eczema. Curious to know, with this pustular eruption on top of the eczema. Yes, good. Wonderful. Yeah. Amazing. So this is impetiginized eczema herpeticum. So whereas impetigo tends to happen a little bit slow over days, eczema herpeticum tends to happen quicker. The patients tend to be more sicker. And I mean, I guess I've been in dermatology since 2009. I've done a lot of calls, seen a lot of patients, and what I can tell you is I don't think I've ever seen a case of eczema herpeticum that wasn't secondarily impetiginized. You can see the honey-colored crusting. So 2 morphologies there. And then let's say you have a toxin-producing Staph aureus that creates flaccid bullae in yellow, clear to cloudy fluid that rupture and leave a colorative scale. It likes children and youth, and they come into the emerge, and they've got this eruption. What do you think this could be? Yeah, great. So you guys are doing really good. I agree, some of these, the pictures might not be the best, but if you see flaccid bullae that often starts to unfold in a young person, do consider toxin-mediated bullous impetigo. So there are two types of impetigo. There's non-bullous impetigo, which is like the honey-colored crusting, and then there's the bullous impetigo, which is truly caused by a toxin-producing Staph aureus, so they need systemic antibiotics. Here's another quick snapper. So what is a reaction pattern characterized by generalized erythema involving over 80 to 90% of the body surface area? We were originally going to do a Jeopardy for this, but I thought over lunch might not be the best idea. Complications might include demand-related cardiac ischemia, high-output cardiac failure, electrolyte imbalance, lymphadenopathy. What is this reaction pattern called? It's not a diagnosis. The diagnosis is many different things, but it's a reaction pattern. What would be, yeah, exactly. Wonderful. It's erythroderma. Yeah. So what are the causes of erythroderma? These are the top causes in adults. And then you see in children, we have to add on immunodeficiencies and ichthyoses. And again, in a way, it is a dermatologic urgency. So in conclusion, a wide variety of urgencies may present to the department. We can use our morphological descriptions and nomenclature to help narrow down differentials, and then looking at the history, the physical, and the drug timeline. Differentiating benign from serious. So again, if like a maculopapular rash, the vast majority of rashes being virus and drug are benign, the patients are not ill, you can follow up with their GP or their dermatologist. But again, if you're seeing kind of this constellation of symptoms coming in that timeline and there's a suspicion, again, do bridge for appropriate care with dermatology. And then may represent drug eruptions, as we discussed. You're going to want to stop the offending agent. Role for dermatologist on call. Again, I know this is a national conference, but I just want to throw out there, I think that it is worth having a hospital-based dermatologist for these sorts of urgencies. It's something that our regions have not been very supportive of, but I think something that's needed. And then the ED physician, again, can help recognize in terms of describing it over the phone, starting an initial workup, and bridging care, for example, internal medicine for admission, ICU or burn unit, and of course, consult dermatology. So thank you for having us. And if there's any questions, we can try to take those.
So we've got about 10 minutes for questions.
Hi, it's John Rizos from Mississauga. Off topic a little bit, but what I noticed is in your introduction that you were going to talk about or consider talking about angioedema. Are you willing to take a question about it?
I could try. I'll be honest with you. I tend to mostly see patients with chronic spontaneous urticaria in clinic, because if someone goes to emerge with urticaria angioedema, I would think probably out of all those conditions, perhaps you're most equipped to recognize and treat it in absence of a dermatologist would be my hope. But yeah, what would that be?
So while it can be categorized in a number of ways, acutely I categorize it as, is it amenable and responsive to epi, or is it not? Does that, it may resonate with emerge physicians. So I guess if you get someone who comes in with an urticarial rash and or lip swelling, some tongue swelling, it may be allergic, but it may be related. Is it C1 INH?
Esterase inhibitor.
Right.
Yeah, I think that's less common. So in my clinic, I usually see the constellation of chronic spontaneous urticaria. So there isn't a trigger that we can find despite extensive history. Maybe even they've seen an allergist. But the cases that I see in clinic is I don't have an acute center is I manage as CSU, so I follow the guidelines with H1 antihistamines. I've never administered an EpiPen in my office, to be honest. It's not a question with regards to EpiPen response that I'm aware of, to be honest. Do you have anything else to add?
Does this work? Oh. It's worthwhile to try, and if it doesn't work, you have to go down your algorithm. I'm not aware personally of any research that that you'll be able to differentiate someone who's reactive or not, unless they have a card with them that says, this is the medication I need when I present with angioedema.
Okay, thanks.
Yeah, sorry, I didn't have a better answer for you.
I guess I'll ask a question. With our dangerous rashes and things that we worry about, do they always present with stable vitals? Can they be falsely stable early on, or are they always usually having some sort of abnormal vital sign?
Sorry, can you say that again? I missed the...
So our dangerous rashes, do they always present with abnormal vital signs, or can they be falsely stable?
Yeah. So thank you. So again, everything kind of being a spectrum. I mean, if this is the way that I would look at it, if someone comes into the emerge and their vitals are stable and there's no warning signs, I think it would be appropriate based on clinical assessment and decision weighing the risks and benefits to discharge the patient, right? Like if they're not unwell or having no symptoms. But, you know, again, things like SJS-TEN, they can evolve rapidly. DRESS syndrome, you know, you can get things like hypotension. So I would say if there's any worry about having some of these criteria to at least monitor them. But again, you know, I would imagine at the beginning, absolutely, they probably would be stable until it starts to kind of progress to that multi-organ involvement. That would kind of be my closest answer, yeah. Do you have anything else to add?
All right, thank you. Any other questions? Okay, so I think we can wrap up. Thanks to Rachel and Tetyana for presenting today. Thank you all for attending. We want to thank members of the scientific community, of course, Boehringer Ingelheim, and all our IT support, and of course our CAEP staff who've worked tirelessly behind the scenes to help us out today. So, as Eric mentioned before, I'll give a plug out to do the evaluations. These sessions have been accredited by both the CFPC and the Royal College, so make sure to claim your credits. And again, please do your evaluations to help us grow for ongoing lectures. Thanks.
Thanks, everybody. I'm going back to Regina, back to my clinic. So enjoy the rest of your conference, and thanks for having me. It's nice to be here.